Hello and welcome to Lecture 2 on Psychological Disorders. So now we're going to look at how psychological disorders are classified and some of the assessment methods for psychological disorders. So again, this is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. They've slightly edited it again, but very mild edits. So, in order to have a diagnosis, a client must meet very specific criteria. And we use the DSM-5 to diagnose patients and clients. And the DSM-5 has 3 sections. The first is an introduction to the manual itself and with instructions on how to use the manual. And then second is the diagnostic criteria for all of the disorders recognized as psychological disorders. And these disorders are grouped so that they're grouped by similar categories of disorders. And then there's a third section that is a guide for future psychopathological research. And this includes conditions that haven't yet been recognized officially. So a good example of this is when you look at the section on addiction and substance abuse. They do include things like gambling addiction, because the evidence that gambling is an addictive behavior is very strong. The research is very powerful. Sex is not included is not defined as an addictive behavior by the DSM-5. And, we hear that term, sex addiction, thrown around so much, but it's actually not a diagnosis. And the DSM-5 talks a little bit about this, that there's simply not enough research at this time to categorize compulsive sexuality as an addiction. So the manual says more research needs to be done on this issue. And it's not saying that more research needs to be done so we can now recognize it as a disorder. It's simply saying more research needs to be done so we can decide whether or not to include this as a recognized diagnosis. But right now, sex addiction is not a recognized diagnosis. So here are the different categories in the DSM-5, and I'm going to let you just read through that. And with each category, you'll see an example of a disorder that would be part of that category. Now, some of these are pretty straightforward. Bipolar and related disorders is going to be bipolar disorder. So bipolar 1, bipolar 2, bipolar not otherwise specified. Sleep-wake disorders. Many people don't realize that insomnia can be categorized as a psychological disorder. Different substance-related and addictive disorders, so alcohol use disorder, personality disorders. If it's a recognized psychological diagnosis, it's in the DSM-5. If it's not in the DSM-5, it is not a recognized diagnosis. Now, one problem with the DSM approach is that it implies that a person either has a psychological disorder or they don't. It's an either-or. And this is known as a categorical approach. The DSM is kind of recognizing that perhaps more of a dimensional approach should be considered. That psychological disorders exist on a continuum, and that people vary in their degree of dysfunction in specific areas rather than in the kind of dysfunction. So, let me check my next slide. So, all people experience anxiety. But those without anxiety disorders have low to mild anxiety. Now, there's always going to be times where they have something that's incredibly stressful, and then they'll have more elevated anxiety. But they don't get into the anxiety disorder part, to the severity of having an anxiety disorder. That's when you look at that on a dimensional approach, you can see that for that population, they're experiencing severe anxiety, and they're experiencing that fairly frequently. So this is more of a dimensional approach, where you look at, okay, are these symptoms simply extremes of normal human functioning, or are they atypical to human functioning at all? The third DSM section is to really kind of guide researchers to examine whether or not a dimensional approach might be helpful for understanding additional psychiatric disorders, such as personality disorders. Research indicates that personalities could be viewed as maladaptive extremes of the Big Five personality traits. This isn't something that I really subscribe to. It's not something that resonates with me as far as the research on personality and temperament. However, I'm not a diagnostician, and I'm not very familiar with the research that's looking at personality disorders and linking that to the Big Five personality traits. It is a novel idea, in my opinion. I just feel like personality disorders also tie in with mood disorders a lot of the time. And so I do think there's more to it than personalities just being maladaptive extremes. Another problem with the DSM-5 is that people seldomly fit neatly into the precise categories that are provided. There's a concept called comorbidity, and this is where a client or patient has more than one disorder. And it may be more than one psychological disorder, or it may be a psychological disorder with some other physical health issues going on. And many of the psychological disorders in the DSM-5 treat disorders, each disorder very separately. So it really separates depression and anxiety. And something that's difficult with that is that a common side effect of depression is anxiety. And so it makes things a little messy sometimes. We know that depression is a common a common symptom for people with chronic pain. That makes sense. Pain is depressing. But also when you look at the brain and how it processes different neurotransmitters, chronic pain can affect the brain, creating a depressive cycle. And if you can get on top of one of the disorders, it helps you get on top of the other. Sometimes it's just rarely do people fit neatly into categories in any aspect of life. Now, it's possible that psychological disorders are comorbid because of common underlying factors. And I do think that that's very much the case with depression and anxiety. We know that with both disorders, serotonin is a very key neurotransmitter. In fact, to treat anxiety disorders, they actually use antidepressants. Now we have anti-anxiety medications too, but the selective serotonin reuptake inhibitors like Prozac, Paxil, they tend to work very well for anxiety, even though the patient may not have depression. And the reason that SSRIs work with anxiety disorders has to do with the serotonin. You're targeting the neurotransmitter. So we see a lot of comorbidities with DSM-5 disorder diagnoses. Oh, sorry about that. We're going to end right there, and I will see you in the next lecture. Thank you.